Good morning, everybody. It's a pleasure to be back this morning to talk. So I've been asked to once again debate Dr. DiMaria on revision surgery. Is it needed for everybody? I don't think it is, and I'm going to tell you my thoughts in just a minute. So I know you saw this yesterday, the ASMBS statement on reoperation of bariatric surgery, and their conclusion is it indicates the outcomes of reoperative bariatric surgery are procedure-specific, but the current evidence does support additional treatment for persistent obesity, comorbid medical problems, and complications. So for some patients, they may benefit from, do some patients benefit from revisional surgery? And I think absolutely. A failed adjustable gastric band, a GG fistula, sleeve to duodenal switch, or a stage procedure, and sometimes a sleeve to gastric bypass. But most patients in which the appropriate surgery, in my opinion, was performed initially will not benefit from revisional surgery for additional weight loss. And here are some reasons why. I think obesity, as you all know, is a multifactorial chronic and relapsing disease. Our body tries to defend the degree of adiposity and promote weight regain, or that set point theory, which is very, very strong. There's multiple physiologic and metabolic contributors to promote regain despite what surgical intervention we do. We've all seen patients that have had a duodenal switch and can gain back weight without any fault of themselves. So these are the physiologic and metabolic contributors, I think, that are against us for many patients for long-term weight loss success: hormonal adaptation, metabolic adaptation, surgical genomics, or that genetic factor that I talked about yesterday, gut microbiome, which is very interesting in an up-and-coming field with regards to obesity, recidivism, and diabetes remission, intestinal permeability, taste receptors, and adipocyte signaling, or that neurobiology. So I just want to briefly, I have one slide, I think, on each. So I think this is really important. Weight loss disproportionately affects appetite. So this is a weight loss 10-week trial on a liquid diet. You can see very nice weight loss, not that you guys can achieve with surgical, but for medical, about 8 to 10%. This individual average weight loss was 14%, but you can see a significant disproportionate drop in leptin. You know, leptin is the hormone that's produced in the stomach or in the adipocytes and travels to the brain, and it affects appetite. So a reduction in leptin makes us feel like our adipocytes are not filled, and so it increases hunger. And you can see even with a slight increase in weight, the weight is still 9%, so there's weight regain, but still there's still a disproportionately low in leptin. And that, I think, is an important driver. And in addition, these incretins that you see, leptin, PYY, CCK, insulin, and amylin, are all decreased. And unfortunately, ghrelin, which is a hunger hormone that's produced in the stomach, is up significantly. So this is the hormonal adaptation to increase appetite after weight loss. There's a physiologic reduction in the obese state, so this is the metabolic adaptation. So when we lose weight, we lose lean body mass, and we lose lean body mass, our metabolism decreases, basically. So that's why, as Dr. DiMaria, I think, said yesterday appropriately, exercise is really not effective for weight loss, but it's very effective for weight maintenance, especially in the surgical patient because of the decrease in lean body mass. Remember, that is the determinant of our resting energy expenditure. So this just says Mrs. Jones or Mr. Smith at 220 pounds needs about 10 calories per pound, 8 calories for women, 10 calories per men to maintain our weight. Mr. Jones needs 200, he needs about 2,000 calories per day. He loses weight to 200 pounds, and then he now needs 1,830 calories. So there's a disproportionate amount of calories that we take in with weight loss. In your surgical patient, this is really important. That's why exercise is so key, not so much for weight loss, but for weight maintenance. As I touched on yesterday, there's a genetic predisposition to weight regain. It's not as clinically relevant as we once thought, but it does have that background. And I'll just point out these rare variants that override a lot of that in the BMI greater than 50. The gut microbiome, a lot of research being done with that. As I said, recently microbiome changes in human, so they change to increase absorption, and it also changes bile acids, which affects GLP-1. And then these are the changes that you can see. The one that's been getting the most research is this Proteobacter, a significant increase after gastric bypass, and that's one of the reasons they think we can modulate to affect weight regain and maybe with diabetes remission. Intestinal permeability, this is what happens after weight loss. There's a change and alteration in the intestinal permeability to increase absorption of more carbohydrates after weight loss to protect that set point theory as we talked about. And then finally, the taste receptors. We think of taste receptors only on our tongue, but really there's taste receptors in our whole GI tract. And they they're proteins, and you can see that they have an effect on taste, specifically sugar and saltiness. And if you recall, there's some patients after surgery, about 12 months or so, that have a significant change in their taste receptors. So they may crave salt or they may crave sweets. We're trying to look at those changes in taste if it affects weight regain, and we have questionnaires and things that we're doing. The other thing that's important to see that I think is that these affect L cells and GLP-1. Those are the endocrine cells in the GI tract, and that has been shown to promote or help with continued weight loss and weight maintenance. And then finally, the adipocyte physiology, which I think is really important with regards to weight loss and weight regain. We all know that an adipocyte, once it's occurred, it doesn't, when we lose weight, we just lose the triglycerides and the fatty acid. The fat cell itself never goes away. And with obesity, once the fat cell is filled, unfortunately, it doesn't just stay like that, it divides, and then it'll divide again. And so when we lose weight, we have all these fat cells. They may have lost their triglycerides and fatty acids, but they're always present. And they have, with regards to leptin and other hormones, a significant impact on our brain that we talked about yesterday with our satiety center and our hunger center wanting to be filled again. So I think that is a really important concept to understand. Next slide. Thanks. So in summary, this is just a schematic of things that we talked about. I don't need to go into that. So if not revisional surgery, what? So I think adjuvant therapy, by definition, add-on or adjuvant care is a therapy that is given in addition to the primary initial therapy to maximize its effectiveness. And if we look, diet, exercise, and behavior modification need to be the cornerstone prior to surgery, but after surgery with weight gain, there also is very, very important. And that's where I think the association or the working together with the obesity medicine specialists in the surgical fields, or bariatric surgeons, we can do great things together. So this is just a slide looking at combination therapy, combination of diet, exercise, and when you combine the two, it continues to improve weight loss. And if we add pharmacotherapy, we can even improve weight loss even greater. The other thing I'll just say, and I mentioned it yesterday, I think weight maintenance is different from weight loss. So you really want to try to intervene early in your patients that are gaining weight, because we have the best chance of making them on the right path rather than going up or a U-shaped curve. So I'm not going to go into all of these. These are all centrally acting medications except for orlistat. Orlistat is a lipase inhibitor that blocks 30% of all ingested fat. All these other ones are centrally acting medications, including liraglutide. People don't really realize that liraglutide is FDA approved, at least in the States, for diabetes at 1.8, and 3 milligrams of liraglutide is Saxenda. So it helps peripherally for insulin sensitivity, but it also is a very potent appetite suppressant. And it also helps with craving with regards to satiety. And then finally, there's newer medications coming up. So the cousin of liraglutide is semaglutide, and it's FDA approved in the States as for diabetes. But if you look, this is a significant, this was not a weight loss trial, I just want to add. This was looking at different doses of that. But you can see after 1 year, 16% weight loss with semaglutide. For a medication, that's pretty good. I mean, anything we can get in double digits. Now, it's not competing with bariatric surgery. I don't want you to think you're going to be out of work. There's really no medications that can compete with the weight loss that you guys achieve. But I think in combination with what you do with medications, that's what chemotherapy does with adjuvant treatment. So finally, this is longer than I thought. I apologize. I hope we're on time. Although bariatric surgery is safe and effective in terms of weight loss and amelioration of obesity-related disease, revisionary surgery may not add the benefit of continued weight loss if patients start to gain weight. And that's why I would just say that, even if you have an opportunity of 6 months or 3 months or 2 months, see what your patients can achieve, because that may guide you in the right procedure, the correct procedure, or most appropriate procedure first, because I think that is really important. So thank you very much, and I look forward to hearing Dr. DiMaria.